Sobha Sivaprasad. I'm a consultant in Moorfields Eye Hospital in London. I don't know how to take this. That side, is it? Okay. Ophthalmologist in tackling diabetes. Are you hearing it? Yeah. So I think all of us are very aware of the global diabetic epidemic. All of us are very familiar with this map as well. So the question is, what do we do for this? As an ophthalmologist, of course, we have got our own ways of tackling this. But we should also remember we are doctors, and as doctors, I think we should tackle diabetes in addition to diabetic retinopathy. So the Indian diabetic epidemic is even worse when compared to the rest of the world, because the prevalence of diabetes is yet to increase several times fold compared to Western countries. In the UK, we have only a prevalence of about 4%, but the prediction is that the NHS will go bankrupt within the next few years due to the cost of the complications of diabetes. In the UK, 10% of the NHS budget is spent on complications of on diabetes and its medications, out of which 80% is spent on complications to deal with the complication of diabetes. So it's a very big hazard all throughout the world. So how can we contribute is the first question. We can contribute by just dealing with diabetic retinopathy. As you all know, a third of patients will have diabetic retinopathy, but only 10% will have sight-threatening disease, and that's the group we deal with on a day-to-day basis. We can tell these patients when they come in that they have to control their blood sugar, because we know from the UK PDS that both hypertension and diabetes should be optimally controlled to decrease the rate of progression of the disease. We are not very good at advising them to control their lipid levels, although we have recent trials on the field study and the AIOC study that show that phenofibrate may help in reducing the risk of progression of retinopathy, but even the general practitioners do not prescribe this as yet. So this is all what we are doing today. What we are thinking of is, can ophthalmologists go one step further? And as you know, diabetes does not only affect the eye, it affects many organs in the body, as you can see from this figure. And we as retinal specialists or as ophthalmologists should also be aware that if a patient has proliferative diabetic retinopathy, it's an important predictor of nephropathy. It's also a predictor of cardiovascular disease and death, and probably a diabetic feet as well. And if a patient has diabetic macular edema, these patients are twice as much risk of developing stroke or myocardic infarction. So can we advise these patients to also see a general physician or their respective specialist physician? As part of an Ornate India project, which is done between the UK and India, we have a study called the Smart India study, where we as ophthalmologists are leading this pathway to see whether we can holistically screen a patient for diabetes as well as its complications. So we are ophthalmologists, but we are going to go around 20 centers in India looking at urban, semi-urban and rural areas to do house-to-house visits and diagnose patients with diabetes if they have not been diagnosed as yet. Do a urine test for them so that we can check their nephropathy for them. Very simple test of blood pressure, which will allow us to refer them on to a physician. And of course, our non-mydriatic photographs for diabetic retinopathy. So as an ophthalmologist, we are able to do this very simple test as well. So this is our approach. So we will do a diabetic retinopathy screen, a urine albumin, and a cardiolipid check for the rest of the complications. What are we expecting? We are expecting a few patients to be diagnosed with diabetes for the first time, diagnosed with hypertension for the first time. We will newly detect retinopathy. We can also then understand that the patients have microalbuminuria and refer to their respective physicians. So you can see how as an ophthalmologist we can also look after their general health and ask them to go to their physicians in time. And if we are able to do this type of holistic screening, probably we can also reduce the rate of mortality in these patients. We may think that is a study, but within the Kerala government, we were also able to incorporate a diabetic screening pathway into their national non-communicable disease strategy. In that, we are insisting on an urine albumin test and a foot examination as well. So we are dealing with all microvascular complications, although it is led by ophthalmologists. So in addition to just detecting other complications, we are also very hungry for data, for high quality data to come out of India. We need to know the relative prevalence of diabetes complications, stratify risk according to their risk of complications. We have to get data to inform the government about changes required to ensure a whole body screening for people with diabetes, to ensure scalability and sustainability of such program. We also have an opportunity to educate patients, and hopefully it will produce a global impact in all other countries where the primary infrastructure is not good enough for patients to have their diabetes or their microalbuminuria diagnosed. So the question is, should ophthalmologists lead the way? Because diabetic retinopathy is the most common complication of diabetes, and the fact that it needs technical expertise, despite the fact that we have artificial intelligence, I think we can only add 2 more tests. We seem to see more patients with complications than any other specialty, so we should lead the way. End of the day, we can only lead the way. The patient still has to attend several multidisciplinary teams as well to get themselves sorted, but we can start the process for them. Thank you.